For many of you, this is probably going to be pretty basic. Some of you, this might be some new information, but truly the intent of this is to provide a baseline and a starting point for everybody. So as we add additional, more complex subjects such as specialty drugs or alternate funding or 340B or clinical programs, we have a relative baseline of understanding of PBM, or a 101, if I may. So bear with me if you've heard this before. I think down the road, it'll become, I think, even more of intrigue and interest to folks on the line here. We are recording this, so if anybody wants the recording, we'll be able to provide that hopefully as well. So, brief introduction. Most of you, I think many of you have know me, have known that I've been in the employee benefits arena for over 22, 23 years. Started out in the TPA space with PPO, Preferred Provider Organization contracts, stop loss, and then medical TPA administration. And back when I started, PBM was truly an afterthought. It was just something that came along with the TPA. I think most of us refer to it as the good old days when drugs were, you know, pennies on the dollar as it relates to healthcare expenses, maybe 7 or 8%. Before specialty drugs, before rebates, you know, weren't as prevalent as they are now. And truly, as I stated, PBM was more of an afterthought. I ended up getting out of the TPA space, joined ClearScript, coming up on my 15th anniversary this December 3rd. So I've been in this space for quite a while now, and I'm excited to be part of this journey because of the prevalence and the significant challenges we face in the self-funded arena as it relates to prescription benefit management or pharmacy benefit management. So happy to be here. I know almost all of you, and really appreciate your time today. So we're going to start with a ClearScript overview, just for visibility. So ClearScript, the organization I represent, has been in existence since 2005. Wholly owned business unit of Fairview Health System. For those of you that don't know, Fairview is a nonprofit health system up in the Minneapolis, St. Paul, Twin Cities market. We do have some facilities on the Iron Range, Hibbing, but predominantly Minneapolis, St. Paul. We're part of Fairview Pharmacy Services, and Fairview Pharmacy Services is I would say, arguably, if not confidently, I can say it is the most prestigious and receives the highest marks of any specialty pharmacy within the nonprofit health system space in the country. So we're very proud to be part of Fairview Specialty and Fairview Pharmacy Services. So we draw from their expertise and their employees, and Fairview has, 30, 40,000. ClearScript has 40 employees. So we have 40 dedicated employees specifically assigned to our clients. And like I said, we do draw from Fairview Pharmacy Services and Fairview Health System as well. We are a nationwide PBM. We carry TPA and PBM licensure nationally. We're a nationally recognized specialty and mail pharmacy provided through Fairview. And we have a national retail pharmacy network of all major chains, and I would say 98, 99% of independents out there. We fill prescriptions for members in all 50 states. Annual pharmacy spend of around $259 million, 57% of which goes into the Fairview family, 3% margin from an operating income standpoint. We service around 231,000 members, 136,000 of those in the health plan TPA space, 85,000 in the health system critical access space. We have 9 tribal nations and their enterprises as well, but 10,000 members in the tribal nation market, and that is the tribal markets. It is national, so we do support tribes in a number of states nationally. So PBM 101, like I said, and I just want to restate this, this is going to be pretty basic information because this is the starting point of a strategy we have to build a webinar series and provide information. More in depth down the road, but high level for this first presentation. We're going to start out with a poll. And I hope this works. What is that poll? I can't see it on mine. Do you know what AWP stands for? And your options are average wholesale product, Association of Writing Programs, average wholesale price, or ain't what's paid. If you'd all click a button there and take a guess.
No button, Kyle.
Be on this side.
Should be on the side. Submit one. Well, I will apologize for any.
It's okay, I'm not seeing it either. It's
we
modern
do-
technology.
It's technology. Well, it looks like 78% actually.
It's in the chat.
It looks like yeah, you have to
Average
open up. Sorry, you have to open up your chat box.
Oh, where's my chat box here? Chat box.
Yeah. Well, it looks like 78%, 91% selected average wholesale price.
Correct.
We've got average wholesale product 8%. We have ain't what's paid 8%. Oddly enough, I guess you could make an argument that it is C or D, and we'll get into that because I think many of us affectionately refer to that as ain't what's paid, even though the correct answer for today is average wholesale price. So I want to start out just by, I think one of the most important things to do is level set on acronyms. And in our space, I've mentioned TPA or third-party administrator. We have TPAs on the call today, dealing with PPOs or preferred provider organizations or HMOs, health maintenance organizations, or HRAs or HSAs or FSAs. In the PBM space, we inundate the market with acronyms as well. And many times we'll go into a meeting and somebody will ask or tell us to please slow down. What does that acronym stand for? So commonly used acronyms, this isn't an exclusive number, but I think this is really encompasses many of them. PBM, Pharmacy Benefit Manager, AWP, Average Wholesale Price, MAC, Maximum Allowable Cost, WAC, Wholesale Acquisition Cost, MTM or Medication Therapy Management, Utilization Management, QL, which is Quantity Limits, ST, which is Step Therapy, Prior Authorization, PA, OTC, Over the Counter, ZBL, which is either Zero Balance Limits or Zero Balance Logic. Once in a while, you'll see ZBD, Zero Balance Due. We'll get into what these mean. And then usual and customary, UNC. So average wholesale price, the reason why it can also be affectionately referred to as ain't what's paid is it is a term where the metric is intended to inform third party of pricing. That was the intent, but with a lot of the pricing mechanisms in the PBM space, those numbers are often inflated to upwards of 20%. So that's why it's often referred to by brokers and TPAs and employer groups as ain't what's paid. But that's what AWP stands for. And philosophically, the intent was to come up with a metric where parties would have a relative idea of what things cost at a wholesale level. MAC, which is your maximum allowable cost list, which applies to generics. That is a payment metric contractually agreed to in the market by all participants in this healthcare continuum. Essentially, the goal of that list was metric used to reimburse pharmacies for generic prescriptions so that consumers didn't overpay for their generic medications. That is, those two, AWP and MAC, are likely going to be a future webinar regarding what exactly is AWP, what exactly is MAC, and what questions can be asked or what you should look for in your contract to get your hands around both of those, because that's where a lot of the levers are pulled from a PBM standpoint. And oftentimes that's where a number of revenue streams are made in the MAC area for PBMs. Wholesale acquisition cost, or WAC, which is at the pharmacy level, how their acquisition cost on those medications. Medication therapy management, which this would probably be a topic for later as well, but MTM is more of a consultative, hands-on approach to managing complex patients with multiple disease states or therapies. And that really came to the forefront with Part D requirements, but you'll hear MTM referred to quite frequently. That can either be done in a clinic setting, or oftentimes we're seeing it now from a virtual setting in a telemed type program. Utilization management, which I think we all know are programs put in place to monitor and make effective and practical use of something, whether that's prescription drugs, whether that's procedures done in the hospital setting through a TPA or under a TPA model. Quantity limits, obviously limits set forth to both protect the health and safety of the member, but also prevent stockpiling of medications and manage costs at the employer level. Step therapy, people probably have heard quite a bit about regarding trying an initial medication, largely based on effectiveness and/or especially cost, with the expectation that you have to try an initial medication to step into a subsequent medication, something that all PBMs deal with every single day on every single plan. Prior authorization, put in place to review when something is deemed necessary and appropriate, and that's done prior to the dispensation of that medication, usually set oftentimes at a dollar threshold. Over the counter medications that are now available over the counter, oftentimes not applied behind or dispensed behind the counter and or applied to the benefit plan, although sometimes are. Zero balance limits or logic is something that is in a contract that allows a pharmacy to collect in the entire copay, regardless of what the claim adjudicates at. So if the copay is $10, but the cost of the drug is $6, they'll actually allow the pharmacy to collect the full 10. When you don't allow that, the member only pays either the copay, the lesser of the copay, or the adjudicated cost of the claim. But you'll hear ZBL frequently, and then usual and customary, which is an average price charged for something or by most providers for services rendered. What are pharmacy benefits? Pharmacy benefits tied into the medical and pharmacy, obviously from an employee benefit standpoint. On the far left, you have medical and pharmacy, dental, vision, life, disability, both short and long, flex administration, FSA, health savings account, HSA, accidental death and dismemberment, legal. Most of you on the phone, I see there's some HR folks as well. You're dealing with this. With all of these programs, pharmacy is just a part of your daily activities as it relates to your employee benefits. From a health benefit standpoint, medical, pharmacy, dental, and vision. From a pharmacy benefit standpoint, what we do, prescription drugs that are on the formulary and covered, providing both retail and mail retail 30 or retail 90, so a 3-month supply in the retail setting, and a mail benefit, which is 90-day supply provided through mail, specialty, and compounding. So we do fit intimately into the benefit design. And as I stated when we first kicked this meeting off, years back, it wasn't as prevalent, or PBM wasn't as looked at as hard as it is now, based on the costs that pharmacies are contributing to the overall expense of the benefit plan. What is a PBM? We are obviously a claims processor. Started as a way of standardizing payment to pharmacies, reducing administrative burden, and ensuring timely payment. Timely payment to the pharmacies that are filling those prescriptions. Before a PBM, there was a lot of administrative burden at the retail pharmacy level, and they were collecting payments. It wasn't as timely. So the initial philosophy of the PBM was really to reduce that administrative burden and get those pharmacies paid quickly. A benefits administrator. So as a PBM, we provide call center and drug information support, and also clinical programs. And that's both from a formulary standpoint and a utilization management standpoint. So the formulary is the preferred drug list. So what drugs are on the formulary and where they're tiered, whether they're preferred or non-preferred. And obviously benefit design ties into that to drive utilization of certain drugs on that formulary. But in addition, we're looked at to provide utilization management. So spotting trends, spotting utilization, and putting in place clinical programs to help manage the cost of that benefit plan and provide better outcomes from a health standpoint. We are often a benefit advisor, and that falls into typically a PBM's account management team. That account management team, the way that we're structured is pretty consistent with other PBMs, but there may be some differences here. But where you'll often have like an account coordinator that'll handle a lot of member communications and interactions and day-to-day reach outs. And you'll have account managers, which are looking at more strategically what's going on with a plan, making recommendations, really at install or implementation of a group. And then even more as importantly, if not more importantly, what sort of recommendations are going to be made long-term, because our clients are self-funded employers. Our clients are paying the bills. It's their money that's being paid out. So clients are looking for guidance and recommendations to manage that cost as best as possible and provide good financial and health outcomes to the members. Financial modeling. So I think it's very important for a PBM to bring guidance to how a group is performing, and also benchmarking against other clients, other books of business. We see that a lot in our tribal book of business, comparing them to our tribal book versus other tribal books of business nationally. Our healthcare clients, how healthcare system ABC stacks up against XYZ, so that we can make we can provide information to help our clients make informed decisions. And then financial negotiators. So a PBM is a financial negotiator, setting up and managing their pharmacy networks, or those pharmacies that are dispensing a medication for both, a margin that they receive on the drug, but also for their dispensing fees. And then pharma manufacturers. PBMs are managing that relationship with pharma manufacturers, which is now more important than ever, based on the cost of medications, especially in that specialty channel, but also based on the rebates that are received back from manufacturers tiering in a PBM's formulary. So very much a financial negotiator on behalf of the self-funded health plan, or in some cases a carrier in their fully insured plans. All right, so how do the payments work? It's a very complex. I think I've showed this to many of you, but we've laid it out here so you can see it, that where the premiums flow from the consumer to the health plan or payer. In this case, that health plan payer oftentimes is the self-funded employer with a TPA processing the claim. The benefit back to the consumer obviously is health benefits. That health plan hires a PBM. The PBM controls manufacturing, controls that relationship with manufacturing. Manufacturers want to obviously create and stimulate or drive their own drug market share. So to do that, they pay rebates. Those rebates are received back to the PBM. The PBM then distributes those rebates back to the plan. We will have a separate webinar session on rebates, because this is extremely important now, based on, what is a rebate, how rebates are received, what you have to do to get to qualify for a rebate, chasing those rebates, and obviously giving those rebates back to the plan is extremely important in the cost healthcare equation here. So we'll have a session on that. The PBM obviously provides or has a contract with the pharmacy, pays the plan share for the drug cost, provides it, that pharmacy then gives a discount back to the PBM, and that kind of cycles all back for the members. And then at the bottom, you have pharma manufacturers that are connected to the PBM and also connected to the wholesaler. So the pharma sells the drug through their wholesaler that fills into the pharmacy. And then the wholesaler pays the wholesale drug cost back to pharma. Brief history of PBMs. PBMs really became a force in the 1990s. PCS out of Arizona, acquired by Lilly, Medco, Paydex, acquired by Merck. DPS locally here, acquired by SKB. Pharma divested in the 2000s. I think a lot of us saw the consolidation in the 90s, and most of us then saw the pharma divesting the PBMs in the 2000s, and PBMs then consolidated PCS into Caremark, Medco, and DPS into Express Scripts. Now we're seeing the vertical integration between health insurance carriers and PBM and pharmacy. So you have CVS, Caremark buying Aetna. You have Cigna buying Express Scripts, ESI. It became Evernorth. And you have United Health Group buying Pacific Care, becoming Prescription Solutions, buying Prescription Solutions, also buying Optum RX, Innovient, which then becomes Optum RX. PBM market share by total equivalent prescription claims managed, and this is 2020, so just slightly outdated, but pretty accurate. 32% of the market share is controlled by CVS Health or Caremark, 24% by Express Scripts and Ascent, and 21% by Optum RX. And you'll see that, in terms of covered lives, mid 80s to high 80s. I've seen some numbers in the low 90s that they're estimating that CVS and Express Scripts and Optum control, either directly, meaning the PBM is CVS, Express Scripts, or Optum, or indirectly, meaning a PBM uses one of those three as a back room. The big three control the lion's share of the members and the lives available in the U.S. market. Falling under that, you have Humana Pharmacy Solutions, MedImpact, Prime Therapeutics, and all other PBMs, including cash pay. The reason why we show this is there's TPAs on this call, or brokers that work with TPAs and carriers, similar to how you all have challenges with BUCAs, the Blue Cross, United, Cigna, Aetna, Humana. We have those same challenges based on the market being dominated by CVS, Express Scripts, or Optum. So poll number 2. So here's just a general question. Do you think PBM market size is financially beneficial to your plan? Does Kevin have a question?
Sorry, I just didn't see the poll,
Oh.
the chat, or I'm not sure where that is.
The meeting chat. If you hit chat, it should be under meeting chat.
Sorry, I can't find
That's
it.
okay.
I'll work on it later. Thanks. Sorry.
Yeah, and Kevin, this poll is we just added this feature to our webinar, so we're working out a few of the kinks. So I do apologize. Hopefully that'll be a little better next time. But do you think PBM market size is financially beneficial to your plan? So if you're an employer, if you're a TPA, or if you're a broker, do you think that it's beneficial to your benefit plan? We have 79% said no, 78, 21% said yes. I am interested to find out the reasons why, maybe during the questions and answers. I'd like to know the reasons why the three think yes. And there are some reasons why that could be perceived as leverage, or that leverage could be perceived as beneficial. Generally, what we have found in the space is, if you're answering this question as a shareholder or a stockholder or one of the big three yourselves, then the leverage, obviously it is beneficial. But we have found with many of our clients, many of the benefit plans, and this just, this isn't exclusive to ClearScript. If you talk to other PBMs, and I think this discussion happens at the TPA level on the medical with clients versus insurance companies, is the perception that bigger is better. We have found that oftentimes that leverage that the big PBM has benefits themselves, oftentimes on the backs of the self-funded employer and the members. So it isn't always a result of bigger is better. And that's really going to boil down to what's a sort of financial arrangement you're in with your PBM, what sort of contract you have. One of our discussions down the road from a webinar standpoint will be PBM contracts, what to look for in your contract if you have one, what to ask for, and what you should do when you're evaluating that PBM contract to make sure that you're getting the best deal possible. And from my perspective, and this is, my opinion maybe personally, but bigger's not always better when choosing a PBM. And I think you always have to ask yourself that question of who benefits from the size and leverage. If your contract and your arrangement enables you to receive the full benefit of that size and leverage, then yes, it's beneficial. But oftentimes the contract doesn't provide that or doesn't enable that. So truly the entity that's benefiting is the organization, which is the PBM. Top pharmacies by counts. So when we look at from a pharmacy benefit manager standpoint, right, you have to have a network of pharmacies. You have to have access, and the member needs to, be able to go to a pharmacy and get those filled. Walgreens has 48, almost 49,000 pharmacists, around 9,300 stores. CVS Health has around 31,000 pharmacists and 9,900, almost 10,000 stores. And then Walmart, those are the big three. Why is this important? Well, if you analyze or look into your pharmacy data, your reporting that you receive from your PBM or your carrier, you're going to see your top pharmacies. You're going to see your top pharmacies by spend. Those three are those two, Walgreens and CVS, are often your most expensive pharmacies. Walmart is lower from a cost standpoint typically. And then there's other local pharmacies as well. So this is all part of the strategy of identifying where those prescriptions are going and perhaps putting in place strategies and solution to drive to lower cost pharmacies to help better manage your pharmacy spend. Total pharmacies by revenue, CVS Corp. So even though they stand second from a pharmacist and store standpoint, they stand first from a revenue standpoint. Walgreens is second, Express Scripts, Cigna is third, and then obviously you can go all the way down to the next 13. So your top five, just sort of highlighting that, enlarging it. You can see here where most of the revenue's going to the big pharmacies. Whoops, sorry about that. And interestingly enough, if you dive into these and look into the more of the reports and more data, it's interesting to find out what channels those are coming through. Are they coming through the retail? Are they coming through mail? Are they coming through mail and specialty? That's the latter is where you're going to find the majority of their revenue coming. So what does a PBM manage? Processing and payment of pharmacy claims, plan sponsor costs, typically on a per member per month, and obviously trend. We're going to get into a cost equation here. But yeah, what we're managing, it's very important to note when we're working with a TPA or when we're working through a broker and we've got a self-funded employer, that organization is hiring us to process claims based on their plan. It's not a ClearScript plan, it's that employer's plan. We are hired to process and make payments of those pharmacy claims. We're also looked to provide benefit administration, consumer support, so member call centers, drug information. When a member calls in to find out what's, what a preferred drug is versus a non-preferred, other information that they might have from a utilization management standpoint, et cetera. Simple to complex benefit designs. We have, some of our clients, and you're going to see this with other PBMs, have a very simple plan design, branded generics. We don't see as many of those anymore, but there are some out there. To complex benefit designs, to coinsurance and out-of-pocket, to a min-max with multiple tiers, multiple levels of coverage. And then coordination with the medical benefit. For years in the 90s, early 2000s, pharmacists, and still pharmacists are still fighting to become part of the care team, which we think is huge missed opportunity. You need to have the pharmacist filling the prescription and providing that oversight, an intimate and integral part of the care team, especially based on the fact that drugs represent a quarter, if not a third, of the healthcare dollar now. Specialty is 54, 55, 56% of that pharmacy spend is specialty, driven by a couple percent of the plan members. So it's imperative now that we combine that information and coordinate that with the medical benefit. It's not just about it's not just about giving the member one card, but it's about coordinating with that third party administrator, that medical benefit plan administrator, to optimally manage member holistically, medical and pharmacy. So look for PBMs that are doing that and can show you a proven track record and results. Financial discounts, network discounts, once again, retail 30, retail 90 just means 90-day supply filled at a retail setting. Mail order, specialty, compounding, we're seeing compounding might also be a good webinar topic, because we're seeing that pop up quite frequently. Pharma manufacturer with rebates, price protection, and then we're also seeing value-based programs. So not just looking at a cost of a drug or the rebate on a drug, but also looking at value-based strategies, producing or optimizing beneficial, positive health outcomes based on the drugs being utilized. Okay, so this is the framework for the 97% of a planned cost. So this is your healthcare, your pharmacy cost equation. Plan paid, which is the total drug cost, that equals ingredient cost, which is, on your per RX, plus the dispensing fee minus the copay. So when we look at the plan cost, we look at the ingredient cost of that drug, or what that pharmacy is being reimbursed for from the drug standpoint, the dispensing fee that pharmacy is paid, less the copay. Many brokers or many TPAs or even groups will ask, you have $1 dispensing fee. Does that go to ClearScript, or it's a 50-cent dispensing fee? Does that go to ClearScript or our current PBM? That dispensing fee goes to the pharmacy. So the pharmacy itself gets reimbursed ingredient cost plus a dispensing fee, less any copay based on the plan. And moving from left to right in the bubbles, network, you're providing access, the AWP minus discounts, which are average wholesale price minus MAC, maximum allowable cost for generics, usual and customary, multiplier, zero balance logic. You're also looking at the formulary or your preferred, non-preferred drug list, specialty list, what are specialty drugs, and what network is put together to fill those. Step therapy and quantity limits, brand and generic definitions. So what is classified as a brand or what is classified as a generic? And compounding. The dispensing fee from a network standpoint is set up retail, mail, and specialty. Those will vary based on the channel. And then copay, your benefit design, copay, coinsurance, deductibles. We're now seeing a lot of coupons, alternate funding programs from a patient assistance program, specialty tiers or tiering specialty medications. Gone are the days, there still are some out there, but gone are the days of a specialty prescription just being processed at a $10 brand claim. If that's happening, that's costing a lot of money. So we're starting to see multiple specialty tiers in benefit plans. And then from a utilization standpoint, prior authorization, exclusions, OTC equivalents, medical versus pharmacy. So clinic infused drugs, are those being applied under the medical, or is that medication coming through the pharmacy? 90-day versus 30-day adherence, which is it's not just MTM, which is more complex, but adherence, just making sure that the member is filling a prescription and we're giving them reminders to go and get their medication filled. Those lapses obviously could lead to potentially ER visits or other medical claims. We want to make sure that members are adherent. Partial fill programs, which you'll hear about from PBMs. Just a program set forth so you're not shipping out a 30-day supply. Maybe you're shipping out a 15-day supply to make sure that the member is responding to it, so you're not wasting 30 days. We're seeing that a lot on the biologics based on a member's body's ability to metabolize a drug with the different therapies. So partial fill programs, when available, can be very advantageous to a benefit plan. And then clinical management. Interesting, of the 97% of the plan, of the total cost, 97% of the plan costs are housed in those bubbles. 3% in terms of just the PBM cost, 3% applies to the PBM. So that's claims processing, drug, call center, drug information, operations, finance, sales support, and account management. Obviously that varies based on who the PBM is, what sort of contract they're under, whether they're under traditional or pass-through models, what their rebate contracts look like, et cetera, et cetera. So one of our last slides here, why we're seeing the acquisitions in the market. Obviously, there's a goal to improve or increase market share, and that's horizontal expansion via obviously competition. We're seeing some new markets expanding within the PBM space, but also oftentimes PBMs can gobble that up based on an insurance company buying a PBM and vice versa. We're seeing technology advancement. Some other organization out there has new technology or better technology. So instead of building it, they're buying it through an acquisition. And then obviously personnel expertise. They want to, buy solid teams to bring them in-house. We've seen United Health Group, buying obviously Optum RX's in-house prescription solution, Catamaran RX, which was Catalyst and EBRX. You had Innovient that they purchased. They purchased a number of PBMs. Anthem launched in-house in 2020 IngenioRx. Aetna through the CVS Caremark purchase, Cigna through the Express Scripts purchase, and Humana currently in discussions with Walmart. So we are at time check 12:42. The goal was really to have this question and answer at around 12:45. So I think we're pretty much right on track. We're going to open up the floor to questions and answers. You can either unmute and ask, or you can send one through a chat. But I just want to open up the floor if there's any questions and answers from the content of the slide deck.
It was probably so thorough, nobody has a question, Kyle. Good job.
I have a question. This is Kevin. Do you guys foresee any making any acquisitions or partnering with other organizations outside of the Fairview relationship?
So like smaller PBMs or other PBMs? So like where we would go and acquire them?
Yeah.
Partnership? I think that the short answer would be, always open to discussions. If it makes sense strategically. As an organization, as ClearScript, we're very proud to have been started within Fairview Health System for Fairview Health System. And I'll preach that story till the day I die, or at least till the day I retire. That we're very proud of that because there just hasn't been that story. So we're very focused on health systems. We're very focused on tribal nations. So tribal nations is a passion for us corporately, and it's a passion for me personally. I love working with Native American tribes and their enterprises. We've got a lot of school district business, and the large lion's share of our business is through TPAs. It's not through insurance carriers, it's through third-party administrators. So if there are ways to partner with organizations where we are going to bring a better mousetrap, better efficiencies to those markets that we serve, I think we would always be open to that, to having those discussions. But it really has to fit into our compartments of who we are and who we want to serve, if that makes sense. So I tie it back to, how we were founded as part of a nonprofit health system. Doesn't always jive with other corporations' objectives, financially speaking. Our philosophy is different, and then the markets that we serve doesn't always jive. So that's why, there's folks on this call that are strategic brokers we work with because they look at things differently than the market. Strategic TPAs that we work with because they look different. But I think, Kevin, if we found like-minded entities that would be interested, we would be open to researching that.
Thanks, Kyle.
Just on the side, Kyle, I remember when you went there. And that was one of the reasons that we went with you, was because being affiliated with Fairview, we had an opportunity that was different than was available anywhere else when it came to shopping out our PBM. We got a straight answer. We weren't buying it from the TPA. We were picking and choosing what we wanted, when we wanted, and the way we wanted it. And ClearScript's always has followed through with everything they promised and then some. So, I mean, I've never gone anywhere else.
Well, I appreciate that.
I have a question. This is Dana.
Yep.
Thanks for the presentation, Kyle.
You bet.
Do you all do anything in the way of manufacturer's assistance pricing or programs to get the drugs free to some of the clients or some of the end users that are in a group that'll cut back the cost of the insurance program itself?
Yeah, that's a great question, Dana. So the short answer is yes. That is done through Fairview, through our parent company, Fairview. So the longer answer to this, and I did warn you, I sort of get long-winded, but I'll try to make this short.
No, that's fine.
Fairview Specialty Pharmacy has been in the patient financial advocate business for decades now. I mean, that there's always been PFAs attached to our complex, high cost, members that have numerous therapies, all the way back to, transplant patients. Before, when specialty was a specialty, but before it became the specialty that it is today, PFAs have been built into the Fairview model. And that historically has just been predominantly, from a member standpoint, looking to reduce the members out of pocket to $5 or free. You'll see now there's been an enhancement to that in the market of seeking, reimbursement from the pharmacy through or from the manufacturers through foundation dollars and compassion dollars, and paying the entire cost of that drug after a specialty carve out. That's obviously if the member qualifies based on income level and all of that. So there's a lot of estimation and contingencies there. But the short answer is yes, we do that. That's done through Fairview, specifically through Fairview Specialty Pharmacy and Fairview Pharmacy Services, and they've been in that business now for decades. Oh, we have, let's see. Question here. I think that's talking about traditional and pass-through. So we talked a little bit about, I'm often asked how PBMs get paid. How does it work? So I think it's kind of going to transparency. So how do PBMs get paid? Well, that's not a short answer to that one. That's a little longer answer. And that truly will be a topic for a future webinar discussion. But short answer is there are two main models that PBMs incorporate currently, with a third sort of out there. The third being sort of a results-based, almost like a reference-based acquisition cost. There's just not a lot of market share there. So the two main models are traditional spread and transparent pass-through. And the traditional model spread is essentially a result of a PBM having a contract with their client, the benefit plan, and a contract with the pharmacy, and those contracts are different. And the end result is oftentimes what is charged to the plan isn't paid to the pharmacy, and vice versa. What's paid to the pharmacy isn't what's charged to the plan. And there is a revenue stream that's retained by the PBM. The reason why it can be transparent, meaning the contract can state where, this is how we're going to do things, but it's oftentimes not really realized what that value is to an employer, what that employer's paying for those services. It's mainly based on discounts. It's mainly based on guarantees. And it's it's an unknown amount of money being retained by a PBM because they have one contract with the plan and one contract with the pharmacies, and those are oftentimes not very similar. And then you have a pass-through arrangement, and that also is transparent, but I would say is more transparent. So whatever's paid to the pharmacy is charged to the plan. Whatever's charged to the plan is paid to the pharmacy. There's no retention of discounts. And this can also relate to retention of rebates. And the PBM has to then go to their the employer plan or their broker, the PA, and say, okay, here's what we're doing for you. Here's what we're going to charge you to do that. And that revenue stream is generally on a per paid claim or a per member per month or per employee per month. But the employer knows what they're paying and for the services that they're rendered by the PBM. So how you know how much a PBM gets paid is by looking into the contract, asking for the contract, having somebody help you analyze the contract, and trying to identify essentially if it's pass through, how much you're paying that pharmacy in a disclosed manner, trying to get your hands around how much you're paying if it's a traditional spread model. That's more difficult. Oftentimes what we do and others do is a claim reprice or comparison showing what the cost of the drug was with the existing PBM versus what it would have been had they been under a transparent pass-through model. And that savings oftentimes correlates to the difference between a spread versus a pass-through model, if that answers the question. It's very difficult to get your hands around that, and it oftentimes takes a claims analysis to do so.
The short answer is there's the right way and the wrong way.
Yeah. And yeah. And that's your opinion. In my opinion, it's unfortunately, if you're the PBM, that, you know, there could be a right way that differs from us, but you're exactly right, Eric. I mean, we're not doing anything for free. We're, you know, no margin, no mission. We have to keep the lights on, but I think it's important that a client knows what services we're providing and how much they're paying the PBM for rendering those services. All right. Well, so what's next? So what I want to do here is I want to send a follow-up survey. Overall, you know, reaction to this, was it beneficial? Once again, I will apologize. For any technical difficulties we experienced, but I also will, you know, I'll just say this was, we tried to make this as high level and as basic as possible because truly we want this to be the benchmark that we build on as we're building out this webinar series. But in your survey, I would love to hear recommendations that you would have for future topics. If it's, I know there were some representatives from some tribes on this call today. So if there's questions you have regarding 340B, we could have 340B as a topic. Diabetes programs, if you want to talk about traditional versus pass-through models, contracts, rebates, etc. Would love to hear from you because I don't want this to be a ClearScript only. I want this truly to be you all being the owners of this webinar series as well, because our goal is to provide you with education and hopefully better information to help either yourself or your clients in selecting administrators of your pharmacy benefits. So with that, I'll give you all an extra 5 minutes. Sincerely, guys and gals, I really appreciate all of you taking the time today. It means a lot to both myself and ClearScript as an organization, and I hope you all have a happy Wednesday.
Thanks a lot, Kyle.
All right, bye-bye.